Hi, my name is Anthony Decker. I'm a student physical therapist at the University of St. Augustine. I have the student case number 4. My patient is a 22-year-old man with left shoulder pain. So going into the red flags, the first red flag I wanted to mention was the deep aching and sharp pain. So having 3 types of pain to me raises a red flag. So that's why I listed it. The patient was experiencing a foggy feeling of the brain. Just a foggy feeling in general, which could possibly, you know, be impairing the memory or orientation or any cognitive things. Um, and they were also reporting some lightheadedness. This lightheadedness might be due to the very low diastolic pressure as well as the high pulse. The patient was also experiencing nausea, which is possibly indicative of a gastrointestinal impairment or pathology. Abdominal pain, because there is the shoulder pain and the abdominal pain. So 2 different pain sources and sites are pretty concerning as a red flag. I mentioned it earlier, but the hypotension, his diastolic blood pressure is 8 or 45 and normal being around 80. That's very low, especially a low systolic as well. And during the musculoskeletal screen or systems review, there was no reproduction of pain with any test. Range of motion was perfectly fine, and the neurologic screens were negative. There are some concerns, not necessarily red flags, but the elevated pulse. Based on the demographic of the patient, I am a little concerned about a 90 beat per minute, pulse, especially being an athlete and young. The other concern I had was the no bruising. Usually, with a fall or some kind of trauma, you usually have some bruising, and the patient had shown no bruising, which is, again, not necessarily a red flag, but a little concerning. Okay, so for the 3 possible systems that I might think are involved, is the first one is the gastrointestinal. I chose this because of the patient's abdominal pain. It would be good to do an abdominal screening because I could possibly locate the quadrant in which the patient is experiencing pain. With the knowledge of the organs in each quadrant, I can sort of further my hypothesis to narrow it down and kind of know which organs are where, and it'll be helpful because if I know which organs are where in each quadrant, then during palpation skills I can possibly be able to reproduce some of that pain or possibly find any enlarged organs. The patient also experienced some nausea, so again, just another reason why I would want to screen the GI unit or the GI system. The next system I want to screen is the pulmonary. I chose the pulmonary because the patient is, has very low blood pressure as well as an increased pulse, and the pulmonary system is very interrelated with the cardiovascular unit. So, with the low blood pressure as well as the high pulse, that lightheadedness and that foggy feeling that could possibly be from a lack of, the ability to breathe. And with this trauma, this direct trauma, and landing on the patient's side, he could have possibly collapsed the lung or had pneumothorax, which also refers to the ipsilateral shoulder for pain. The third and last system I wanted to screen was the cardiovascular unit. I sort of mentioned a little bit of why earlier with the very low the very low blood pressure as well as the decently high pulse. So the lack or the low diastolic blood pressure may indicate a lack of refill in the blood returning. This could be serious because there might be blood within the peritoneum or possibly the abdominal cavity. His lightheadedness, again, very concerning because it could possibly be due to a lack of delivery of oxygen, which we also did not get a vital sign of. And the left shoulder pain might actually be a referral. Abdominal aortic aneurysms do start typically in the abdomen, however they do radiate kind of superiorly and kind of inferiorly as well out to the sides. The increased pulse, like I was explaining earlier with the red flags, it's not necessarily a red flag, but it is a little concerning because of the demographic of the patient. Like I said earlier, I would expect a 22-year-old athlete to have a lower pulse. However, it might be because of this trauma and the stress and the pain levels could be increasing his heart rate. Okay, one of the first questions I wanted to ask from the OSPRO was, have you recently experienced any vomiting? Because this pain is abdominal in nature, as well as, kind of going to that left shoulder, I wanted to kind of relate it to the pathology of peritonitis. So peritonitis, people usually present with nausea and vomiting, and we didn't go over vomiting within the system's review. Not only with that, peritonitis usually has an increase in pulse as well as a decrease in blood pressure. Okay, so my last question is for the cardiovascular system. It is, have you recently experienced labored or difficulty breathing? I want to ask my patient this because I want to know if, we didn't ask him in the beginning, so, did you have the wind knocked out of you when it happened? Possibly, any difficulty breathing afterwards or, now. And with the symptoms of the fogginess and the lightheadedness, it might be due to a lack of oxygen being able to be delivered to the brain as well as, other parts of the body. Okay, as far as proceeding with the abdominal exam, I believe, screening the abdominal region is the most important thing because the patient is experiencing abdominal pain and because of the different facets of the abdominal exam. That being said, superficial and deep palpation can, provoke pain as well as locate structures and, kind of determine if there's any differences in the contour, in the shape, or if there's any, any masses or anything of that sort. Moving on, we have the auscultation. So the auscultation, we're basically looking or listening for these bowel movements, and we're looking for about 5 to 34 within each region, doing about 1 minute holds. And this, can help us determine if the bowels are hypoactive or hyperactive, depending on if it's less than 5 or greater than 34 respectively. The last test that you usually do is the percussion test. So the percussion test basically demonstrates the different sounds of the different organs within the abdominal quadrants. This will help us determine the size as well as possibly any blockages within the intestines or any feces that may be in different areas. The typical sounds you would hear are tympanic. That's going to be the majority of the abdominal exam. That's basically like hollow air-filled viscera. Then you have the dullness, such as the liver or the spleen, because they are solid organs. You have a flat, which is indicative of like muscle, such as like an anterior thigh muscle, and then you have the resonant sounds, which is mostly a moderate pitch and only found in the lungs. All right, so for my special test, I'm going to be doing a special test for peritonitis to determine if there is a positive or negative sign. It is called the rebound tenderness test. This test is good to determine if there's peritonitis. So we're looking for pain on the rebound. So after deep palpation for about 15 to 30 seconds, we're going to be asking the patient if they felt pain during the palpation or when they released. I'm checking this test because my patient is showing some signs of peritonitis, such as increased pulse, lowered blood pressure, as well as nausea. Hi, my name is Anthony Decker. I'm a student physical therapist at the University of St. Augustine. How are you doing?
Doing well, thank you.
Good. Okay, can I have you confirm your name and date of birth for me, please?
Dominic Decker, September 12th, 1993.
Okay, good. All right, so Mr. Decker, today you came in with some shoulder pain as well as some abdominal pain. We've taken all your vitals and gone through the systems review. So today we're going to be proceeding with a little bit of an abdominal exam, just so I can kind of get the gist of what's going on with that abdominal pain and kind of see where we can go from there, okay? So the first thing I'm going to be doing, I was going to be using my stethoscope, and I'm going to be going through each quadrant. I'm going to be listening, for regular bowel sounds and movements. Then the next technique is called percussion. So I'll be, tapping on my finger and be locating different organs in each quadrant and kind of determining the size and where they're at. And then the last thing we're going to be doing is kind of palpation. Palpation means, locating structures with my fingers. First, I'm going to do a real light one, going about 1 centimeter per, circle, and then I'm going to move to the deep palpation, which is about 3 to 4 centimeters per circle. If it's all right with you, I'd like to go ahead and get your consent to proceed with this evaluation. Is that all right with you?
Sounds good.
All right. Okay, so now I'm going to do my auscultation, the first test of the abdominal region. I'm going to be auscultating all 4 quadrants. As I'm doing so, I'm going to wanting to be holding at each quadrant for about 1 minute and counting the fluctuations or the flushing or the gurgling sound or perhaps the faucet dripping sound. The normal range for most people is 5 to 34. Anything below that would be hypoactive, and anything above 34 would be hyperactive. So, because of my compromised bed situation, my body mechanics might seem a little off, but I would adjust for this in the clinic by raising the table so I wouldn't have to, strain my back as much, as well as I would most likely be able to be seated in a rolly chair. Okay, so just a forewarning, this stethoscope's going to be a little cold. First, I'm going to check, make sure, yep, it's on. Okay, first I'm starting with the right upper quadrant. Okay, hold there for a minute. For time's sake, I'm not going to hold for a minute at every single spot, but that's what I would do if I were to be doing a full abdominal exam. Good. And that was the left upper quadrant. Now I'm moving to the left lower quadrant. Okay, good. Now I'm moving to the right lower quadrant. Good. And he was in the range of about 25 to 30 in each one, which is normal. Any pain or any symptoms with that?
Nope.
Okay, good. All right, Mr. Decker, I'm going to be doing a little bit of abdominal palpation. So like I mentioned earlier, palpation is basically I'm going to be locating structures with my fingers. This superficial palpation that I'm about to do will help identify any superficial masses, any muscular resistance, or possibly any abdominal tenderness. And because you're having some tenderness on your left side, I'm going to be starting on your right side just so I don't, aggravate it and kind of, don't want to aggravate any of the symptoms. So I'm going to be going about 1 centimeter per kind of rotation with 4 fingers. So I'm going to go ahead and start with your right upper quadrant. Is that all right with you?
Yes.
Okay. Okay, nothing really noted there. Moving on to the right lower quadrant. Okay, any symptoms with that?
Nope.
Okay, I'm going to move over to your left side. Okay, now that was the left upper. Now I'm going to go on to the left lower. And what I noted in the left upper was a little bit of fullness, and I'm getting a little bit of fullness as well down here in the left lower quadrant. This could be possibly due to his acute injury of the fall playing hockey, which may have put some internal bleeding in my patient's left flank. Do you have any? Do you have any pain with that?
No.
Okay. So with the superficial palpation, if I notice any involuntary guarding, I could kind of assume that it could be some peritoneal inflammation. And like I said, compared to the right, I found a little bit more fullness on the left side over the right side. Okay, so moving on to deep palpation, Mr. Decker. Be palpating a little bit deeper. So if you have any pains or anything, please don't hesitate to let me know. So like I said, I'm gonna be using this hand as well as a topper hand, and I'll be palpating about 3 to 4 centimeters each time, okay?
Okay.
Is that all right with you?
Sounds good.
All right, so again, I'm gonna be starting away from the affected side because I don't want to, aggravate the symptoms right away. So again, I'm gonna be starting with the right upper quadrant. So I'm gonna be going, like I said, about 3 or 4 centimeters. Good. Any pain with that?
No.
Okay, and like I said earlier, due to the unfortunate situation of the bed not being able to be raised, in a clinic I would raise the bed so I wouldn't have to have bad body mechanics. So moving on to the right lower quadrant, once again, 3 to 4 centimeters. Doing all right?
Yep.
All right, so he did complain of left upper, so I'm going to be starting with the left lower instead. Any pain with that?
Nope.
And again, going 3 to 4 centimeters. Now I'm going to go to the affected region. Any pain with that?
Yeah, that's the same pain I feel in my left shoulder.
Okay, so the patient has stated that he felt the same pain that he came in for in his left shoulder, which is a positive sign for a curve sign. Okay, Mr. Decker, down to our last little abdominal exam test. We're going to be doing some percussion. So again, because you have the pain in your left upper quadrant, I'm going to kind of stay away from that area for now as I'm percussing. So what I should be hearing pretty much throughout, except in certain regions, is a sound called tympany. So it's like a hollow sound. It's usually gas or air-filled, organs. There's also a dullness. So dullness, I'm gonna be looking at your right upper quadrant because there's the liver there, as well as the left upper quadrant. The spleen will be dull as well. Any flat noises are something like musculature or such as the anterior thigh. It's more of a flat sound, no real pitch to it. And then lastly, there's resonance, which is mostly noted in the lungs, and it's more of a moderate pitch. Okay, and the percussion assesses masses, the amount of gas, and can estimate the size of the liver as well as the spleen. With that being said, dullness can also be feces that may be within the colon or large intestines. Okay, so first I'm going to start onto the right upper quadrant. So I should be expecting a dull sound, and actually with the right upper quadrant I can actually measure the size of the liver, and it should be about 6 to 12 centimeters from the mid-clavicular line going downwards. So I'm going to start there. Okay. Now I'm moving to the right lower quadrant. Noted tympany. Okay, good. Any pain or any symptoms with that?
Nope.
And I also noted the dullness of the liver, and it was about 6 to 12 centimeters. So I'm going to start with the left lower quadrant. Noted tympany. Okay, now I'm going to move up to the last quadrant, the left upper quadrant. My patient being my brother, he has a normal dullness sound, which is most likely from the spleen. Okay, so I finished the left upper quadrant. My findings were inconclusive. Any signs and symptoms with that?
It's a little tender.
Okay, and my patient has a little bit of tenderness in that left upper quadrant, but I can't say for sure what it was based on the inconclusivity of the percussion test. I'm going to be performing a special test to kind of determine peritonitis. I'm going to be using the rebound tenderness test. This test is to, like I said, assess for peritonitis, and peritonitis is inflammation of the peritoneum of the intestines. Okay, so first I'm going to palpate the general areas to kind of search for the pain, because I don't want to start at the region of pain. I want to start away from the pain. Okay, so I'm just going to do some palpation. Any pain with that?
Mm-mm.
Any pain with that?
Mm-mm.
Any pain with that?
Mm-mm.
What about here?
That's where I feel the pain.
Okay, so he feels the pain in the left upper quadrant, so I'm going to stay away from that area. So with this test, I'm expecting the pain to be worse on the rebound because of the rapid movement of the peritoneum back to where that space was. That's what's going to elicit that positive sign. So when I'm doing this, I'm going to be wanting to hold for about 15 to 30 seconds as I'm doing it. So first I'm going to start in this. I might as well do McBurney's point, which is halfway between the ASIS and the umbilicus. So if we drew that line, I would be just about here. So I'm going to press in. Doing all right, patient?
Mm-hmm.
And then I'll quickly release. Any pain with that?
Mm-mm.
Okay, so now I'm going to move to the affected area. And then I'm going to release after 15 to 30 seconds. And my findings were negative for peritonitis. There was no pain on the rebound, only pain going into the deep palpation of the rebound tenderness. Okay, so at the end of the test, I would ask my patient, was it more painful on my initial, or was it more painful when I took my hand away? And my patient, if he had a positive sign, he would have said it hurt when you took the hand away. A negative sign would just be, a reproduction of pain while I palpate inwards. And this test should also be used last because it's a pretty invasive test. The last test of all the abdominal kind of stuff. The system I believe to be involved is the cardiovascular system. If we look at the vitals, we can see that he is suffering from severe hypotension and increased pulse, as well as some nausea. With that being said, the organ that I think that it might be that may have been ruptured is not cardiovascular in nature. However, due to the nature of what I found in the abdominal exam, such as the fullness on the left side and the indications of an internal bleed, again going back to the vitals with the increased pulse, possibly trying to make up for it, I still believe the cardiovascular system is part of it. However, my differential diagnosis will be a different organ. For my differential diagnosis, I believe it to be a ruptured spleen. Now, there are many things that point me into this direction. First, we have the injury itself. Our patient had a hard fall during hockey, as well as experiencing some left shoulder pain right afterwards. Um, in the past few days, he was feeling foggy and lightheaded, maybe indicative of internal bleed. He was feeling nauseous, and his vitals were very low. His blood pressure was very low. It was 90/45, and his pulse was increased, also indicative of a possible ruptured spleen. During the musculoskeletal systems review, I was unable to provoke any symptoms, further leading me to check the abdominal region. And during that abdominal exam that I conducted during their percussion test, it was inconclusive on that left upper side. However, the patient noted some tenderness. Moving right along to the palpation, a deep palpation of the left upper quadrant reproduced those same shoulder pains in the left shoulder of the patient. Going to the superficial palpation, as I was palpating the left side, I noticed a more full side on the left versus the right, which again may be indicative of internal bleeding. Moving on to the special test, which was my possible competing hypothesis, was peritonitis, because they present with similar things such as nausea, vomiting, decreased blood pressure, and increased pulse. However, when I performed a rebound tenderness test to determine if the patient had peritonitis, the result was negative, therefore confirming my diagnosis as a ruptured spleen. Okay, so this is what I would tell my patient. I would obviously try and remain calm and, not try to alert them or, freak them out in any way. But I would say, Mr. Mrs. Smith, let's just say, your examination was not like I expected it to be, from a typical shoulder injury based on the trauma. Because after all my tests and measures and ranges of motion and everything that I've tested with that, I found no reproduction of your symptoms. Given your history of playing hockey this past weekend and having that acute fall, you might possibly have some internal injuries. And with that being said, I would rather you go see your doctor first before I go ahead and start treatment. Like I said, I don't want to alarm you, but it may be best to go to the emergency department and possibly see what they have to say. I would also recommend to call your doctor and try to be seen right away. And you can do that from our phone, or if you have a phone on you, that would be best. Okay, so this is what I would tell my patient. I would obviously try and remain calm and, not try to alert them or, freak them out in any way. But I would say, Mr. Mrs. Smith, let's just say, your examination was not like I expected it to be, from a typical shoulder injury based on the trauma. Because after all my tests and measures and ranges of motion and everything that I've tested with that, I found no reproduction of your symptoms. Given your history of playing hockey this past weekend and having that acute fall, you might possibly have some internal injuries. And with that being said, I would rather you go see your doctor first before I go ahead and start treatment. Like I said, I don't want to alarm you, but it may be best to go to the emergency department and possibly see what they have to say. I would also recommend to call your doctor and try to be seen right away. And you can do that from our phone, or if you have a phone on you, that would be best. All right, so this is how I would do it with the calling the doctor. I would call the doctor and say, "Hey, Dr. So-and-so, I have this patient here. He says you are his primary care physician. I did a musculoskeletal exam for the patient's right or left shoulder, and I could not reproduce any of the symptoms that he was complaining about. So as I go through the vitals, he displayed hypotension. And like I said, I was unable to alter the shoulder pain. His pulse was at 90 and his blood pressure was at 90/45. The patient also was experiencing lightheadedness, as well as some fogginess, which could be indicative of a internal bleed. With that being said, moving on to my abdominal exam, my findings were a little uneasy. I found a positive Kerr sign with the palpation of the left upper quadrant. The rebound tenderness test that I decided to use was not positive, and when I was palpating the left side, I noticed the left flank was more full than the right flank, again, possibly indicative of some internal bleeding. Along with my last test of percussion, it was a little inconclusive. However, my patient reported some tenderness. With that being said, I wanted to call you because I wanted to let you know, as well as I let the patient know, that I will not be treating them today, and either I want them to have an immediate referral to you or immediately go to the emergency room because I believe there is possibly some internal bleeding and this needs to be handled right away. So with that being said, I would recommend an immediate referral to the MD without physical therapy. I would not treat this patient based on the vital signs, based on the non-reproduction of pain, and based on the acute trauma as well as the abdominal screen findings, which are indicative of internal bleeding rather than a actual musculoskeletal shoulder injury.